So today we had the 4th summit on the healthcare benchmark, and we talked about data analytics and measuring total cost of care. The entire day focused on how we can better use data and outcomes in a transparent way to make sure that we're really informing total cost of care and anything that we're trying to do in the state to move to paying for value instead of just volume. We had a wonderful set of speakers, and we hope that you'll watch some of these clips.
And it has to come from the people. If you can't get the people of Delaware to buy into this with the government and the health professionals, it ain't going to happen. It's got to be done in what I would call a community participatory way, where people are buy into this. It can't come from the top, it can't come from the bottom, it has to be both from the bottom up and the top down. You've got to actually make this a people movement to make the kind of change that is needed.
What if the stakeholders who traditionally submit data to these kinds of repositories, storing cross-pay or even cross-provider claims data, are not just seen as data producers, but also data consumers, right? Not simply parties to convince or coerce to share their data, but stakeholders who stand to benefit from a collective effort to aggregate, organize, and make this data valuable for improving healthcare in Delaware. Right? Just like when the states moved over to a new Medicaid data system, right, there's going to be costs to conforming to the new structures and systems that will be implemented in Delaware. And if the benefit is all a one-way street, that kind of cooperation may feel out of reach, right? Yet the promise of a shared resource, right, in which all can benefit, stakeholders and then, and then of course patients down the line, with access to billing data, potentially other forms of data down the line, right, may make the cost of participation seem less onerous, right? If there's a benefit, it's a lot easier to show up and do something different.
But here's what we felt we had to do to begin to assemble the information that could really drive better performance, better care, better prevention. So I'll draw you over to the right-hand side of the slide. We started with an Allpayer claims database. And when I walked into Vermont in the end of 2007, I was telling Dr. Walker this, there was an Allpayer claims database almost unused. It was just sitting there. And I was like a kid in a candy shop, really. I can use this thing. Well, now in my work around the country, I can tell you, I can't even count the total number of states that have underused Allpayer claims databases. And how you assemble the rules that allow the use of that Allpayer claims database will determine its value. You are at the front edge of this. You have an opportunity to do this right. This is one of the most pivotal choices you can make. The wrong rules could really inhibit it. But we started with that, and we also had a health information exchange network, although not as advanced as yours and not as capable as yours. It's one of the real strong assets you have.
So let me start off with just a definition of what an Allpayer claims database is. So it is an aggregation of some big data files, okay? And at its core, it consists of really 3 different things. It consists of eligibility files. That is a list of all the members, people who have healthcare coverage through one payer or another. So it has those folks in it and the type of coverage that they've got. It's got claims records, so again, at minimum, probably pharmacy and medical, but sometimes it's got dental and other forms of claims as well that can be included. And the third thing that it's got is a provider database. So it has to have a master provider database, the doctors, the hospitals, of course, but also the therapists, the home health agencies, the DME providers, everybody else. So that's all coordinated and put in there. Your neighbor Maryland was the first to go live with that as part of when they were going with their unified payment system there. But the first, what I'll call modern APCD, was only created, after 2003 in Maine. And that was what we would recognize today as one of these forms of being able to collect comprehensive information on eligibility, payment, etc. The important thing about APCDs is it allows for very, very diverse, flexible, sophisticated examination of healthcare system, healthcare spending.
So our Attorney General's office, like every other one in the country, does healthcare work. We were the first in the country to centralize it in a dedicated healthcare division more than a decade ago. That division does the same work that the Delaware Attorney General's office does in healthcare in other states. Law enforcement, oversight of the rules of the road. We also have unlike some other AG's offices, unlike most other AG's offices, a really robust healthcare policy practice. We do monitoring, we do data investigations, and we release that information back out into the community to catalyze subsequent reforms. The legislature, in its wisdom, inserted a very short one paragraph into our cost containment law, asking the Attorney General's office to take a law enforcement tool, a subpoena, and apply it in a non-law enforcement context. And to date, we're still the only AG's office in the country that has that unique type of subpoena, compelling payers and providers to submit information to our office confidentially, to synthesize that information, and then to release it back out for, again, stakeholder consumption.
Please join us for our next discussion about the healthcare benchmark in Delaware. It will be on November 2nd from 12 to 3 at the Medical Society of Delaware. We hope you'll either join us in person or online.